My name is Ashish Pershad. I practice at Banner University Medical Center in Phoenix. It's a pleasure for me to be broadcasting this lecture for SIF 2020 virtual. I'd like to thank Dave Reisig, Jim Hermiller, and Mark Reisman for inviting me to participate in SIF this year. And my talk is going to be on transeptal mitral valve replacement in severe mitral annular calcification, abbreviated as valve and MAC. These are my relevant disclosures, which are none relevant to this talk. So let's get into this complex topic with a clinical vignette. So the patient I have that I'm going to talk about is a 68-year-old female who had a previous transcatheter valve replacement in 2016 for severe aortic valve stenosis. 29 Evolut R was implanted without complications. She's done well for about 3 years. At that time, her mean gradient across the mitral valve was 6. She had moderate mitral annular calcification. We chose to leave it alone and see how she did after replacing her aortic valve. Now, 3 years later, her mean gradient had gone up to 14. She continued to have class 3 heart failure symptoms. Her MAC had progressed from moderate to severe. She's immunosuppressed from treatment for rheumatoid arthritis. She has severe back issues and there's clearly poor rehab potential due to her immobility from her back. Her STS predicted risk of mortality was 5.8% for replacement. So this was her baseline transthoracic echocardiogram, and you can see that she's got mixed disease. She's got moderate mitral stenosis, as well as at least moderate to severe mitral regurgitation in the right panel on this bicommissural view. A coronary angiogram demonstrated no underlying coronary disease. The previously implanted bioprosthetic core valve is visualized in this cine angiogram. Coronary engagement was not a challenge. And this is her relevant CTA. So now, as you can see in the left panel, she has what we call dense mitral annular calcification, which is quite circumferential from trigone to trigone with minimal involvement of the leaflets. There is a borderline neo-LVOT or skirt neo-LVOT with implantation of the circular sapien 3. Her neo-LVOT skirt was 1.7 centimeters squared, which is right at the borderline for something that we would consider that would be prohibitive to do this without some sort of LVOT preparation. And her aoromitral angle was 122.5 degrees, which is considered favorable. We want to bring to the attention of the viewers a recently published paper that we were involved in that looked at mitral annular calcification and its distribution, thickness, and involvement, and how suitable MAC distribution and calcium was for performing a transeptal valve in MAC. And the take-home message from this paper was that severe mitral annular calcification, defined as a calcium thickness that was 10 millimeters or greater throughout the annulus, gave you 3 points. If it was between 5 and 10, you got 2 points. The distribution of calcium within the annulus, whether it was less than 180, greater than 270, or less than 270, gave you 1, 2, and 3 points. And involvement of the trigone, either side gave you 2 points, one side gave you 1 point, and if there was no involvement of the trigone, you got 0 point. Similarly, leaflet involvement gave you 0, 1, and 2 points. And the takeaway from this paper that is soon to be published in JACC imaging is that if your MAC score exceeded 7, which put you at severe mitral annular calcification category, your likelihood of having an embolization or migration of the valve during implant was markedly lower than if your mitral annular calcification score was less than 7. Having said that, it is not an absolute, but it clearly is a objective assessment of MAC, which hadn't been present up until this time, where I think cases were being done all over the country and the world that had no real uniform classification of MAC, and hence guidance to operators was a little vague. Whereas with this paper, you clearly have a good understanding of what we think is necessary for at least attributes for a safer procedure in terms of thickness of calcium, distribution of calcium, involvement of the trigones, and involvement of the leaflets. Another big Achilles heel for valve and MAC is paravalvular leak, and we've contributed in the literature for a recently available paper in Journal of Cardiovascular CT that looked at predicting paravalvular leak after a replacement transeptally using commercially available software remodeling. Mike Morris, our CT radiographer, was a primary author, and myself was the senior author on this paper, which we looked at a number of cases that were done and used conventional modeling. And the takeaway with that message, takeaway from that paper was that you can predict in the absence of dehiscence of a ring or a valve malposition during the procedure with more than a 90% negative predicted value, the location and extent of paravalvular leak using 3D prediction. And then that way you can plan your strategy of whether or not you're going to plug a hole with a duct occluder or a ASD occluder, and be prepared during the index implant to manage circumstances like that. So going back to our case, we clearly have to dilate the septum. We typically will dilate the septum using a 14 millimeter balloon like you see in the left panel. The transeptal has to be targeted, similar to most mitral procedures, whether it be valve and ring, valve and MAC, or valve and valve, where the access to the left atrium is posterior and inferior. We use transesophageal echocardiography for all our targeted transeptal punctures. Once we've done that, we are able to cross into the left atrium and then into the mitral valve using an Agilis sheath. And once you have an Agilis sheath directing you, use a JR4 and an exchange length 035 wire to cross into the left ventricle, and then switch the 035 exchange length wire for an extra small safari wire. The bend on the extra small safari wire is the opposite direction to what you would normally have, say, if you were doing a TAVR procedure. And we do these procedures with the placement of a temporary transvenous pacemaker, as you can see. Once we've done all the homework and created the environment suitable for advancement of an E-sheath, we then have certain modifications. We don't sew the E-sheath in to the right femoral vein. We will make sure that we are able to load the valve in the inferior vena cava just before entering the right atrium. And we advance the valve with the Edwards logo pointing down. Once we've gotten that orientation, we then are able to safely advance the Edwards sheath across the septum. It's really important to dilate the septum and floss it adequately, because the one thing you don't want to have is your valve, once it's loaded, get caught in the septum, because that would make for a very long day. We have on the left femoral access side a pigtail catheter in the LV with a 5 French pigtail and a 6 French femoral long sheath, so that at all times we're able to monitor real time the presence of any kind of LVOT obstruction. And we are able to keep that on our hemodynamic screen, and because it may become relevant in a case like this when we have borderline neo-LVOT numbers like we did in this case. Once we've accomplished that, we will advance a 29 valve, which was the valve we used in this case, and line it up. This is the hard part where there's a lot of motion, as you can see, due to the vigorous contractility of the left ventricle, as can be seen in the middle panel. But we obviously try to put the dot of the sapien valve within the calcified portion of the annulus with the intention of having a 20 millimeter offset and adequate flaring within the LV. Typically, we would like to keep our pusher on the left side, but in this case, as you can see, the pusher is pulled a little further back than we'd like, and care needs to be made to make sure that the pusher is not on the right side of the heart and is maintained within the left atrium past the interatrial septum in case adjustments need to be made once the valve is being ready to be deployed. Moving on to the final deployment process shown in the right panel. We rapidly pace these patients. The deployment is slow, and you can see that our goal is to flare the sapien valve with a 20% offset in the left atrium, such that you can get full expansion. Typically a 29 valve, we add a few extra cc, usually 4 or 5 extra cc of contrast. And for a 26 valve, we'll typically add 3 extra cc. In this case, we had added 4 or 5 extra cc of contrast. The valve is fully expanded, as can be seen in the right panel. And the minute the valve is expanded, we pay attention to hemodynamics to make sure that there's no compromise in the left ventricular outflow tract. Having first established that, having verified on TEE that the valve location is stable and the deployment is adequate, we then will focus our attention on the 3D TEE assessment. And as you can see on the right panel, the valve seems to be working fabulously. There is a small paravalvular leak at 2 o'clock, which can be visualized. We anticipated that based on the degree of LVOT calcium. But given the fact that she was hemodynamically stable and was tolerating this mild PVL well and was not particularly an active patient, we chose to not chase this paravalvular leak, which was quantified as being mild to moderate. We then checked the gradient across the valve, and the gradient had now been reduced from 14 to 6 millimeters under what were thought to be baseline loading conditions, and which was thought to be an adequate result. Her clinical outcome was excellent. She's had no heart failure hospitalization since this procedure. She's had no major cardiac adverse event, no stroke. Her mean gradient remains 6 at 6 months out, and even at 1 year out. She was treated with warfarin with a target INR of 2 to 3 post-procedure, and continues to get that followed with her primary cardiologist. Putting this in context, I think, is important. This was a case that was done at our institution that has a large experience with doing transcatheter mitral valve implants. But in the left panel, you see the 30-day results in the STS-TVT registry of patients who've had this procedure done. And you can see out of 100 patients that were treated in the valve and MAC group, out of a total of 900 transcatheter mitral valve interventions, the cardiovascular in-hospital mortality was 18%, 1/8, which is tremendously high as compared to the 6% that is reported for valve and valve. Not only that, 30 days, the all-cause mortality is almost 21.8%. Once again, demonstrating that this procedure is still got a lot of nuances and is not something that can be taken lightly. Device success, as reported by the VARC-2 criteria, was a little over 50%, which once again illustrates that valve embolization as well as device stability is still a major concern as we try to circularize an elliptical mitral annulus. Procedural success was noted to be less than 50% in the TVT registry. All of these findings were statistically significant and were clearly worse with valve and MAC as compared to the more traditional, safer valve and valve operation. Going back to the right panel, I'd like to focus on the 1-year results of our mitral 1 study, which looked at our valve and MAC patients, which were also followed all the way out. And this represents a sobering statistic that 50% of the patients are dead at 1 year, reflecting the severe morbidity that these patients have going into an operation like this. Majority of them have high STS scores and are non-surgical. But the interesting thing about this is that when we did a landmark analysis at 30 days, if you survive the first 30 days and don't suffer a procedural mishap, then you do remarkably well. And your mortality between 30 days and 1 year is essentially flat, reflecting once again that all the hazard is upfront from the procedure. But if you can safely undergo the procedure, your 1-year results are actually quite good. These patients have marked improvement in their heart failure class and derive the same benefit as patients who've had a valve and valve or a successful valve and ring operation. In conclusions, my takeaway are as follows. I would think that maybe 30 to 40% of severe MAC cases can be safely treated with the currently available S3 technology, transeptally. We do turn down several cases based on severity of how much MAC there is, as well as the absence of suitable management situations for LVOT, either with lampoon and or with a alcohol septal ablation, which sometimes can be undertaken preemptively to prevent and to increase the LVOT diameter and area prior to deployment. Learning curve is steep for this procedure, and I think is important that only sites that have had experience undertake this, because the outcomes, as you can see from the TVT registry, are sobering. A very good CT analysis is extremely important to not only predict paravalvular leak and manage that, as we've shown from our publication, but also to predict embolization risk. Long-term data for cases like these are still limited due to the small number of patients both in the registry as well as in mitral 1. More data will be obtained in studies like the Medtronic and the Tendyne platforms for severe MAC patients. But we're also embarking on mitral 2, which is the SAPIEN 3 Transeptal platform for severe valve and MAC. Hence, we need to focus our attention and try to enroll patients in these clinical trials so we can get more information and serve our patients better. Once again, thanks for your attention. And it's been my pleasure to contribute to SIF 2020. Please be safe in these unprecedented times. Thanks again for your attention.